მინდა წარმოგიდგინოთ ჩვენი სპიკერი, პროფესორი პიტერ ლანსბერგი, რომელიც არის ექიმი ლიპიდოლოგი, გრონინგენის უნივერსიტეტის პროფესორი, ჰოლანდიის ლიპიდების კლინიკების ქსელის დამფუძნებელი, ლიპიდოლოგიის საერთაშორისო აღიარებული ექსპერტი ამსტერდამიდან, ჰოლანდიიდან. პროფესორი ლანსბერგი, თქვენ ალბათ უმეტესობას თქვენგანს ნანახი ყავს ჩვენს კონფერენციებზე, ძალიან კარგად იცის მისი ლექციები, იგი არის არაჩვეულებრივი სპიკერი და დღეს წარმოგვიდგენს ძალიან საინტერესო თემას დიაბეტისა და კარდიოვასკულარული რისკების, დიაბეტისა და კოვიდის ურთიერთკავშირის შესახებ და ჩვენი ასოციაციისთვის ძალიან დიდი პატივია და ძალიან სასიამოვნოა, რომ იგი დღესაც ონლაინ ვირტუალურად გვიერთდება და იმედი გვაქვს, რომ შემდეგი შეხვედრები უკვე უშუალოდ საქართველოში გაიმართება და იგი საქართველოში კვლავ შეძლებს ჩვენს ღონისძიებებზე მოხსენებების გაკეთებას. იგი ჩვენი ასოციაციის საპატიო წევრია და ეხლა მინდა მას გადავცე სიტყვა. Dear Professor Landsberg, please, you can start. Dear Professor Landsberg, you can start. Thank you.
Okay, dear Nadia, thank you very much for your kind introduction. I had the translator that translated perfectly. I'm pleased and honored to be back in Georgia, although this time virtually. But I hope that in the future I have the privilege to see all of you again. My topic today is a little bit on and off target. As a few of you know, my focus is on lipid management and cardiovascular disease, but I've been very much involved also in looking at the effects of COVID, SARS-CoV-2, and cardiovascular disease. So I think I combined a few items that hopefully help you to better understand what is causing some of the serious complications we see, and also what are good strategies to manage those patients. Now, first and foremost, this is not meant to address the severely ill, the ones in ICU or on ventilation. This is more addressing the patients at risk for being admitted to the ICU or on ventilation, and what strategies could help to prevent these complications. So before let's see if this works, just a second. Yes, so these are my disclosures. I give a lot of presentations for societies like GAM and also for some pharmaceutical companies. The topics I would like to address today is a little bit of background information about SARS-CoV-2, the impact it has on our cardiovascular system. And you will see there is quite a bit of overlap between the effects of SARS-CoV-2 and diabetes and cardiovascular disease, managing diabetes, but also trying to highlight the importance of two drugs or two families of drugs that we use quite frequently for preventing cardiovascular complications, and that I think are important also in patients with risk factors and SARS-CoV-2. So just a little bit of an overview. One important metric that is becoming more and more mainstream now is so-called the R0. The R0 tells you what is the likelihood of one patient that is affected to infect other patients. And just to have a better feeling of the interpretation of this virus versus other viruses, I think this illustration reflects that quite well. So seasonal influenza, COVID-19, SARS, and measles. And I always point out that perhaps we're even lucky that although COVID-19 is quite infectious, it's luckily not as bad as measles, although the new Delta variant might actually be responsible for a better transmission of the virus. Another important metric is, of course, what is the percentage of patients that get very sick or that even die from the infection. And again, I try to give you a little bit of a feeling compared to other viral infections disease such as flu, SARS, and MERS. And you can see that it's definitely more serious as seasonal flu. But compared to SARS and MERS, you can still consider it perhaps a little bit more milder. The only problem is that it's so infectious that many people are now becoming infected and subsequently also suffer consequences. One of the intriguing findings of this viral infection is that young people seem to be fairly well protected. I mean, it's not 100% protection, but it's not very common to see serious complications in the younger generation or in children. On the other hand, the older generation, and especially the very elderly patients, are very likely to suffer complications or even die. And that's reflected by this overview looking at the mortality by age and then comparing flu, as you can see on the left side here, and COVID-19 on the right side. Last, this shows you the global impact of some of the very serious flu infections we had in the last century, in 1918, 1957, and 1968. And this is an update from yesterday, the impact of SARS-CoV-2 on mortality in 2020-21. And you can see already the number of deaths is 4 million. And I think it's even an underestimation. And we're far from having dealt with this disease. So I think we will see in the next year at least a doubling, if not a tripling. I don't think it will become as dramatic as in 1918, but it's definitely a very, very great healthcare challenge. When we first knew about the SARS-CoV-2 or COVID-19, some data from China, there was a lot of information about the pulmonary aspect, on the fact that patients had like a pulmonary infection, difficulty breathing, and that was sort of the hallmark of COVID-19. Very quickly in China, but also in other countries, it became clear that COVID-19 does not only target the alveoli, it's not only a lung disease, but it targets a certain receptor, the ACE2 receptor, and I will elaborate on that a little bit later, that is found in many different organs. And the heart, the kidneys, the brain, the liver, the intestines all have this ACE2 receptor. So if you look at the clinical features of some of the COVID-19 patients, you will find that there are quite a few complications associated with organ failures in these categories. So the ACE2 protein is quite an intriguing protein that was sort of out of our vision before COVID-19, and now it has become really a focus point for a lot of research. What is the relationship between ACE2 and coronavirus is, I think, very simply reflected in this graph. The coronavirus is a corona because it has sort of a crown, a radiance of these spike proteins, and these spike proteins, after being activated by the transmembrane protease serine-2, the TMPRSS2 protein, can attach to the ACE2 receptor and become internalized in the cell, and then the cell machinery will start replicating this protein. The function of ACE2 is also quite diverse. You can see that in the kidneys and in the intestine, it has more a transport function. It transports amino acids. In the pancreas, very relevant for our diabetic patients, it's involved with insulin secretion. And in the lung, it's sort of a focal point for inflammation and infection. What is also quite relevant is on the right side of the slide is that ACE2 converts angiotensin 1 and angiotensinogen 2 into angiotensin 1 to 9 and angiotensin 1 to 7. Now, what is important to realize is that if you look at the the conversion from angiotensinogen to angiotensinogen 1 and 2, and finally its uptake by the angiotensin 1 receptor, the signal that is being produced is pro-inflammatory, is harmful. It has a harmful effect on the blood vessels. On the other hand, angiotensin 1 to 9 and 1 to 7, which are formed with the aid of the ACE2 protein, are actually cardioprotective. So keep that in mind when I come to address drugs affecting the renin-angiotensin system. ACE expression is present in many organs, but it's not in all organs in a similar fashion. You can see it's very highly expressed in the intestines, but also in the lungs and in the heart, and perhaps slightly less concentrated in the brain or in the central nervous system. Although we do know of quite a few reports showing that the virus does affect the central nervous system, not only by strokes, but also by certain neurological diseases. And one of the most prominent ones that I think many of you are familiar with is the problem with smelling and tasting that's affected by the virus. So the capillaries, they carry the blood and also the virus, and then it comes in contact with the endothelium, and a damaged endothelium makes it also more vulnerable for the virus as well. Now, and I've listed here some factors involved with endothelial dysfunction that do translate eventually into higher risk of experiencing COVID-19 complications. Very prominent, and I think that's very well recognized now, is the cardiac effect of SARS-CoV-2. ACE2 receptors are present, and the virus creates not only inflammatory effect and a hyperinflammatory response, but also because of the hypoxia in the lung infection, the cardiac muscle cells are lacking oxygen, and that has an effect on plaque ruptures, on ECG abnormalities, and even on coagulation problems. So the cardiac system, the cardiac vascular system, is really a central organ system affected with SARS-CoV-9. What are risk factors? Quite a nice overlap on risk factors for cardiovascular disease, risk factors for diabetes, and also risk factors for COVID-19 or expression of complications in those triads of serious diseases. This shows the impact of different risk factors on hospitalization. And you can see hypertension, obesity, diabetes, cardiovascular disease are quite prominent in this list. What are predictors of mortality? That's depicted here in this slide. And I think the two most prominent ones are patients that manifest cardiovascular disease and patients with manifest type 2 diabetes. Again, this is not a generalized high risk. Other risk factors come into play. So very well controlled type 2 diabetic patients at an optimal weight and properly managed, the risk of getting complications are far lower compared to a diabetic patient who is not well regulated and not well managed in terms of risk factors. The direct effect of cardiac damage has been shown in quite a few studies. In clinical features and looking for markers of cardiac damage in patients admitted because of COVID-19 infections. You can see this is the list of cardiac problems they found in those patients. Now, please realize there's also an overlap because most of these patients are elderly, they're over 60 or over 70, they probably have other risk factors as well. So they are most likely to also have already cardiac manifestations, although maybe they were not previously diagnosed before admission. So again, it's overlapping circles, but it does point out that the heart is really a system very vulnerable in this type of infection. What are prognostic indicators for cardiac damage? Well, I noted them here. There are some biomarkers. There are some markers related to endothelial function and platelet activation, and also, of course, ECG abnormalities. So now let's go to diabetes and COVID-19. One intriguing observation in the beginning of this epidemic was that patients who were admitted to the hospital because of COVID-19 suddenly developed also type 2 diabetes. So they were not diagnosed with diabetes prior to admission, but during admission, it became clear that their glucose was abnormal. And here you can see an overview again of numerous studies, and there is a huge difference between those studies, most likely also because of different patient characteristics, going from 0.6% in the Chinese study to almost 62% in one of the US studies. Overall, the estimate is roughly that 14%. So 1 in 8 patients develops diabetes during their hospitalization. Now, part of that might be related to the fact that diabetic patients also have a higher expression of the ACE2 protein. This is comparing non-COVID and COVID patients, diabetic and non-diabetic, in terms of ACE2 protein expression. And you can clearly see that the COVID patients have a higher expression. So that makes them also more susceptible to becoming affected. And especially the diabetic patients have a higher expression compared to the non-diabetic patients. There is also an indication that the receptor ACE2, but also the TMPRSS2 protein can become glycosylated, and that makes them even more vulnerable for the virus. And here you see the expression on the left graph on glycosylated ACE2 versus on the right side, the TMPRSS2 protein. Again, similar observation, higher in diabetics, and again, higher in COVID-19 diabetics. During their hospitalization, and then focusing predominantly on diabetic patients, almost half of them develop cardiovascular complications. And that can go from myocardial cell damage based on biomarkers to full-blown cardiac arrest or myocardial infarction based on plaque rupture. So cardiac monitoring is really relevant in those diabetic patients once admitted. In those patients that died during their admissions, you can see again that the expression of ACE2 is more predominant in the ones that have diabetes, and that there seems to be a preponderance of the virus entry in cardiomyocytes of diabetic patients. Overall, diabetes by itself is a disease with a high risk for infections, high risk for cardiovascular disease. There is, we know, a defect in the innate immunity, which is not helpful if you have a viral infection. There's also problems with cell-mediated immunity. Again, that's something you don't want with a viral infection. It's prone for cardiovascular disease. I think that's sort of the mainstream that we now use to address diabetes type 2. It has also a risk of diabetic ketoacidosis, which by itself is a very serious complication not only in a general hospital situation, but also in patients, or even more so in patients hospitalized for COVID-19 complications. Chronic hyperglycemia and also subclinical inflammation are other factors that do play a role in the expression of COVID-19. Intriguing, perhaps, for some of you to realize that DPP4 seems to also have some affinity for the SARS-CoV-2 virus, and that blocking the DPP4 receptor potentially has a mitigating effect on the expression of the disease and the damage of the cells using DPP4 receptors as an acceptor for the virus. So DPP4 antagonists are somewhat higher up the list when managing patients with type 2 diabetes. Now, what are the best strategies to manage patients in hospital situation with diabetes and COVID-19? And this is the strategy used in the Harvard Joslin Diabetes Center. Basically, it's the same what you do for all patients with diabetes managed in a hospital setting. Glycemic control, proper monitoring of parameters relevant for stability of the disease, definitely monitoring cardiac and renal function. Specifically for COVID-19, you might try to boost the immune system a little bit, vaccinations for flu or pneumonia, but also some some vitamins or metabolic high content diet might be appropriate in COVID-19 patients. And last but not least, if possible, I mean, in a hospital situation where patients are seriously ill, that's not really realistic, but in home situations where patients are just managing disease, doing regular exercise does have a protective effect as well. Now, what about medication? Of course, metformin is first and foremost, but there is a chance of dehydration and lactic acidosis, and you really have to carefully monitor renal function. SGLT2 inhibitors, although very effective and successful in managing patients with diabetes and combined with heart or renal problem, there is also a risk of dehydration, and you have to monitor renal function probably as well. Then we have the sulfonylureas and the DPP4 inhibitors. I think they, especially the latter one, are quite interesting because, as I said before, the DPP4 receptor might be involved in the attachment of the virus. TZDs are not well advised. They increase your risk of heart failure. And also GLP-1 analog have to be monitored quite carefully because of dehydration, and you need to monitor intake and fluid intake. So first and foremost, and again, I want to underline, this is the hospital situation. Insulin is the drug of choice, frequently monitoring every 2 to 4 hours. Check of ketones, and you might have to increase insulin because of the severe disease state of the patients with diabetes. One hallmark of managing patients with cardiovascular risk and also with diabetes are, of course, the ACE inhibitors and ARBs. And in the context of the ACE2 receptors, when we first start to learn about this disease and recognize its features, there was a little bit of apprehension because there is the chance that ACE inhibitors and ARBs could increase ACE2 receptors. And ACE2 receptors are the entry point for the virus. So people were worried that that would increase your risk for cardiovascular complications. And this is some mainstream media that reported on that. As I mentioned before, we have to really understand a bit better how the system works. And as I said before, the AT1R, angiotensin 1 receptor, is in fact a pro-inflammatory and a receptor that translates into a harmful effect in the cells. While on the other hand, the angiotensin 1 to 7 seem to be having protective effects. And what you see is that with using the ACE inhibitors or ARBs, you do see an increase of the expression of ACE2 receptors. But the fact is that you might actually have a beneficial effect because the ACE2 is responsible for the transformation of angiotensin 2 to angiotensin 1 to 7. And that's depicted here in this slide. So here you can see that ACE by itself has that effect on angiotensin 1, 2, and that by giving an ACE inhibitor and an ARB, you have a positive end result of less inflammation, less fibrosis, and that should translate in better outcomes. And that is actually what we notice. Oh, this is just a little bit of a different view. This is looking at patients that used ACE inhibitors or ARBs, but these were patients that were exposed to influenza, to the flu. And what they found is that the longer you use these class of drugs, the lower your risk was actually to get infected with flu. And although it's a little bit dangerous to extrapolate, but there might also be a protective effect of these drugs, maybe for infections with the SARS-CoV-2 virus. I think all professional societies involved with blood pressure management or ACE inhibitors and ARBs have now embraced that the use of ACE and ARBs should be continued. We shouldn't be scared to use them. And there is even some indications that they might have beneficial effects. Similar discussion about statins. Statins, first and foremost, lower LDL cholesterol, as you can see here in the middle of the slide. I want to see if I can point it. It's here. But statins have other effects that might actually contribute to better outcomes in COVID-19. So there are indications that it could inhibit virus replication. It has some immunomodulatory action. Of course, we know it prevents cardiovascular damage. It protects endothelium. It has some anticoagulant properties. And what is also quite relevant that we know this drug very well. It's extremely safe. It's low cost, and it's generally available in practically every country on this planet. Now, just a brief highlight, when you talk about statins and the effect of statins, a lot of focus is, of course, on the pathway on the left, that by inhibiting the steps in the cholesterol synthesis, you end up by inhibiting cholesterol synthesis in the liver, and that upregulates LDL receptors and lowers your blood cholesterol. On the other hand, and that's on the right side, some of these intermediate metabolites are also inhibited in their production, and that might also have beneficial effect. We think it's relevant for cardiovascular disease, but it's also relevant for SARS-CoV-2. Now, this is a dose-dependent effect. It's not that the same amount of non-cholesterol lowering effect are found with 10 or 80 milligrams. So I always tell colleagues and also patients that the percentage of LDL reduction also reflects to a certain extent the pleiotropic effects of statins. Now, this is a little bit of a complicated slide. I just want to highlight that we do know, based on numerous publications, there are different effects that we can expect from statins. There is cholesterol-dependent effects, like lowering LDL, reducing oxidized LDL, and subsequently reduced foam cell formation, but also cholesterol-independent effects, isoprenylation synthesis, down-regulation of Rho kinase, NF-kappa beta, and anti-inflammatory signaling, and even HMG-CoA reductase in independent effect that altogether could translate in better outcome. Just to remind you about the importance and relevance of these anti-inflammatory effects, one of the old studies, the Armida recapture study, really underlined that statins are not only cholesterol-lowering drugs. What they did is, prior to a PCI, patients were given 40 and 80 milligrams of atorvastatin 12 hours and just prior to the PCI. And they were followed for 30 days to look at outcomes. So 2 tablets within a time frame of 12 hours does not really impact LDL cholesterol. And I will not go into the details, but I just want to highlight here, these are MACE, so major coronary events, that were reduced in the patients who were given the 2 tablets. And it's distinct different between stable angina and acute coronary syndrome patients. And what that illustrates is that in acute coronary syndrome patients, there is a much higher inflammatory status. So having a higher inflammatory status and then giving an anti-inflammatory statin was translated in a significant reduction of events. I mean, this was also observed in the stable angina patients, but you can see the impact was not as pronounced as in the unstable patients. We now have some data collected in different studies looking at the impact of different medications and risk factors, and just highlighting here the bottom graph showing the impact of ACE inhibitors and statins. It does seem to be related to better outcome, lower risk of complications. Another way to look at the impact of statins, these are 6 graphs. Now, the top 3 graphs are all the hospital admitted patients. The bottom 3 graphs are the surviving patients in the hospital. And then they looked at CRP, IL-6, and neutrophils as reflection of inflammation. And you can see that in the blue line, which were the statin users, those markers were significantly lower compared to the patients that didn't have the statin on board. And that becomes even more pronounced in the survivors, where you can see that the patients who didn't survive had actually an uptick of these inflammatory markers, while the patients that did survive and had a statin had actually a stabilization or even a downward trend. So one of the conclusions in this article, but also in many other articles, is that statins must be used in patients at risk for cardiovascular disease. Statin is not, the silver bullet that can address COVID-19 or that can prevent infections or prevent all kinds of complications. But it does play a very important role in patients at high risk, just as cardiovascular patients or diabetic patients are high risk and statins are indispensable. And in that context, we should not stop statins. We should not stop ACE inhibitors or ARBs, because they do contribute to some extent in better outcomes. Now, there's one caveat I have to underline as well. If patients become very seriously ill and they have to start medications that could interfere with the metabolism of the statin drug, that could be a reason to stop or temporarily stop these drugs in order not to endanger the patient for side effects, either with statin overexposure or with overexposure to the drugs given to address that. One of the, I think, best hospitals in the world is the Massachusetts General Hospital, and this is their flow diagram of how to manage patients admitted with COVID-19. And I just want to highlight this. Consider statin if cardiovascular indication. So if patients are admitted, they don't have statins, and they do have risk where statin should be administered, don't hesitate to do that. And they also provide an extensive rationale on their website why they think statins are important in that category of patients. Now, from observational studies, it looks that statins contribute quite a bit in reduction of risk, but observational studies do not provide us with the real solid evidence. So although it's tentative to say, oh, maybe we should, be more generous with statins, I think we have to be careful that we don't overdo it and provide that drug to patients that perhaps don't need it or might even be harmed by those drugs. So try to keep in the framework, as mentioned here as well, patients at risk for cardiovascular disease and at risk or with manifestations of COVID-19, their statins and also ARBs and ACE inhibitors are indicated. What we do need are, of course, randomized controlled clinical trials that provide us with the evidence, the data, that they really work. And this is an overview of some of the trials that are still ongoing and that hopefully will give us more solid answers about this problem. So to conclude, I hope that I made it clear that COVID-19 is a systemic vascular disease. It's not a predominantly lung disease, but I think most of you will be quite familiar with that. COVID-19, diabetes, cardiovascular disease share many common risk factors that can be addressed in a very similar fashion. In hospital-admitted patients or diabetic hospital-admitted patients, insulin seems to be the preferred choice to managing their hypoglycemia. Don't stop ACE inhibitors and ARB in COVID-19 patients if there is an indication for these drugs, and the same for statins. Use high-dose, high-intensity statins in patients at high risk for atherosclerotic cardiovascular disease, and in that context, if there is no contraindications, also in patients with diabetes or cardiovascular disease admitted for COVID. And last but not least, we are waiting for the randomized controlled trials to learn what are the potential effect of statins, maybe in a broader context, in a prevention setting, and hopefully that will be addressed in those studies. So this was my last slide, and I hope I gave you a little bit of an overview. I mean, it's impossible to go into the details. The amount of data being published on a weekly basis is phenomenal. Per week, between 1,000, 2,000 new publications come out, and it's almost impossible to keep track of everything. So what I did, I tried to highlight some of the things that I think are quite relevant and important for you to know. Thank you very much for your attention, and please don't hesitate to ask questions now or to send me an email or send me a tweet. Thank you.
Thank you so much, Professor Landsberg. Excellent talk as always. We missed your talks, your presentations. Thank you for being with us today. We have questions for you. And I hope very much that next time we can host you in Tbilisi, in Georgia.
Yes.
Yeah. So now the question from our colleague, pediatric endocrinologist, who has discussed this case with me, but yeah. We could not conclude what would be better in this case, and we decided to use this opportunity to ask you. It is not about this the COVID, but still about the lipidology. So Nino has a patient and asking about her patient. Dear Professor Landsberg, I would like to use an opportunity to ask you about my patient. She's 6 years and 10 months old child. She was, as well as her mother, had genetically confirmed familial hypercholesterolemia. Mother, of course, is treated with statins, and I'm not sure, should I start treatment now or wait till she's 8 or 10. The girl has no symptoms so far. There is a history of early, up to 30 years, cardiovascular disease in the family. Her lipid levels are as high as total cholesterol is 9.7 millimole per liter, and LDL is 8 millimole per liter. It is a more than 310 milligrams per deciliter. The HDL and triglycerides are normal. So should I start statin treatment in 6 years and 8 months old child? Which one and which dose? What should I watch out for? It is quite hard for her to be on a diet. She is not involved in any organized physical activity due to COVID restrictions. So thank you so much.
Yeah, so this is a classical case of children with familial hypercholesterolemia. And on the one hand, we have a nice framework of guidelines that tell us what to do with children with this serious disease. And we also have to use our common sense and what patients, or in this case, parents, and maybe the girl itself wants. Now, I do think that starting statins in such a serious FH, because having such a high LDL is really serious, should begin very early. I have a sort of a cutoff around age 8 or 9. And the reason, I think I explained that earlier in one of my previous visits as well. If you wait until the children reach puberty, you have big debates, you have big discussions, and to be honest, in 80 to 90% of the cases, they won't even take it. Mm-hmm. I remember even homozygous patients that were diagnosed around puberty who refused apheresis, who refused treatment because of the life phase they're in. Mm-hmm. Children who are treated earlier, and again, to help you remember, McDonald's uses the Happy Meals to target children below the age of 8, because anything that you sort of embrace below the age of 8, you take with you the rest of your life. Okay. And on a more positive note, the same for brushing your teeth. You know, there's never a debate with a pubescent girl about, shall I brush my teeth or shall I not brush my teeth? So starting early, I think, is really important, and it makes it so much easier in the long run. Now, the exact date, I think, because we have this discussion, I would favor starting now. I mean, she's almost 7 years. In Holland, we usually start between the age of 6 and 8. The reason is that at that age, children go to school independently, they have their own friends, and you want to make sure that, you know, the strategy is already embedded in their lifestyle and not a discussion or a debate. The type of statin, we used to really focus on pravastatin in the past, and that was because all the trials were done with pravastatin. I know from my pediatric colleague that they also feel very comfortable with atorvastatin and even rosuvastatin. I would aim for a target. So in these young children, you probably need a high dose of atorvastatin or rosuvastatin. Now, realize that it's a smaller human being. So the same amount of drug for an adult of 120 kilo is now being administered to a smaller individual of maybe 30 or 40 kilos. So you would start low and see what the impact is. Target levels in terms of LDL, I would be very happy if you can get that LDL below a level of 2.3 or 100 milligrams per deciliter. I think that would be a very ambitious but very good target to aim for, and also for the parents to have something to hold on to. Start with a lower dosage, say 20 milligram or 10 milligram, and then up titrate to see how it goes. The experience with children in terms of side effects is that they very, very rarely report side effects. Mm-hmm. Serious side effects are also very, I mean, you can never say never, but it's very rare. Muscle-related side effects that are frequently reported by older patients are very rarely reported by children.
And we do not have pravastatin in Georgia.
Yeah.
We have atorvastatin, rosuvastatin, and pitavastatin.
Yeah.
which one would be your preferred one?
I would prefer atorvastatin. And the reason is that we know most about atorvastatin in terms of efficacy and safety, but I feel comfortable with rosuvastatin as well. And I would start with 20 milligram and maybe up titrate to 40 milligram to see how she responds.
Atorvastatin, you mean, yeah?
Atorvastatin, yeah. Or if you go for rosuvastatin, start with 10 and then go to 20. I think that probably, I'm not sure if that's available, she would need ezetimibe as well. And to be honest, if her mother has a similar phenotype, I'm sure her mother uses also the high dose statin plus ezetimibe to get her LDL under control. So then they can share that they use the same thing. That's a little bit of bonding and also feels quite comfortable for the mom and for the daughter as well.
So you would prefer to up titrate statin or to add ezetimibe if 20 milligram of atorva would not be enough?
I would first up titrate. I would go to 40 milligram and then add ezetimibe if that's possible.
Yeah. Thank you so much. It was very interesting and very informative to listen to your experts' opinion. Now, there are questions. I will read these questions in Georgian because questions are in Georgian and the translator will translate you in English, okay?
Yeah.
ლიანა ჯაშიშე კითხვა არის ბათუმიდან. მერსის დროს სამიზნე რეცეპტორი იყო DPP4, ხომ არ არის რამე კვლევა ამ მხრივ COVID-19-ზე? ამაზე ისაუბრა პროფესორმა ლანსბერგმა, მაგრამ ალბათ მაინც კიდევ გააკეთებს კომენტარს. და პოსტ-კოვიდურ პერიოდში ძალიან ხშირია ვიტამინებში B12 ვიტამინის დეფიციტი. პაციენტებში ხომ არ გაქვთ რამე ინფორმაცია ამ მხრივ, ან ამ დროს მიმდინარე ჰიპერჰომოცისტეინემია, ხომ არ შეიძლება იყოს თრომბოფილიის ერთ-ერთი გამომწვევი ფაქტორი? მადლობა. მადლობა ლია შეკითხვისთვის.
I'm not quite sure if I understand the question.
Okay, the question is that there are two questions. So one question is about the DPP4. I think you already mentioned this, but maybe once again, focus on this issue. And then the second question was about vitamin B12 deficiency in COVID patients. And maybe the doctor asks, could hyperhomocysteinemia be connected or correlated with a thrombophilia in patients with COVID-19 with vitamin B12 deficiency?
So in terms of DPP4, and that's not my personal experience, I'm not a diabetologist, but that's what was communicated to me with my colleague from Harvard. And they said that DPP4 would be a first choice in patients with COVID-19 and diabetes to manage them. Once they're hospitalized, he would prefer to use insulin and close glucose monitoring, perhaps also with DPP4, although then, you know, the virus has already attacked the body. So it's not that you can protect entry of more virus by starting then with the DPP4 agonist. The second thing about manifestations of the disease, and I think thrombotic and also bleeding manifestations is a huge challenge. And although we have a lot of patients with these complications practically in every country in the world, there's a lot of publications as well, it's still a very sort of mix and match type of patient group. There's younger, there's elderly, there's patients with risk factors, there's patients using aspirin, there's patients, you know, it's very difficult to distill what is exactly the problem and how to properly address that. And I do recall that just recently there was a paper coming out that said that early heparin treatment in COVID-19 infected patients did produce a better outcome in the long run, less hospitalizations and better mortality outcome. Other than that, I think we have to be very careful to jump onto conclusions. Yeah, homocysteine could play a role. I don't know, but we do not yet have the proper studies. Vitamins, I think, are important, but simply measuring the vitamins can already help us in determining if it's low. You know, if vitamin D or if vitamin B12 are low, definitely I would try to supplement it. If it's not low, then the question is, does it really contribute when I supplement these vitamins?
Thank you. Next question is in English.
Yeah.
So I will read it directly. Professor Peter, thank you for very evidence-based, probably, and interesting presentation. Can you give us some evidence or tell us about your experience with type 2 diabetic patients on metformin in post-COVID period? How is their homocysteine status? As we know, homocysteine is a big risk for cardiovascular disease complications and thrombosis, especially in type 2 diabetic patients. And have you do you have some recommendations about plasma B12 vitamin G? Again,
To be honest, I don't have a clear answer for this. I mean, I think almost 10 years ago, we were very focused on homocysteine, vitamin B12, folic acid, because there was a hype that was so relevant also in the prevention of cardiovascular disease. Now, when the trials came out, the randomized controlled trials in patients with hyperhomocystinemia that were given these vitamins, we realized there was no impact. It didn't really contribute to better outcomes. So after these trials, I think most of the people working in this field sort of abandoned it and let it go. And I haven't seen any very good publications on this topic within the context of COVID-19. So I think we have to be, again, like I said before, we have to be careful not to jump on the wagon when there is one very promising report, because as we learned with you know, the anti-malaria medication, the ivermectin, there have been a lot of, you know, touted miracle cures, and in the end it inflated like a lost balloon. So try to keep to the standards that we use in our normal practice in terms of having a lack of a nutrient or a vitamin or a mineral supplemented, but not enthusiastically, you know, start providing everybody with supplements and believe that will prevent them from having COVID-19. Realize, and that's also important to realize, yes, quite a few patients get sick, but the majority doesn't get sick. So it's very temptive to look at those that don't get sick and think, oh, that's because I gave him zinc and vitamin D. Look, because they all are well now. Yeah, but 95% of the patients do not get sick. So that makes it a very difficult evaluation, and you have to do that in a proper study setting.
Well, the next question is in Georgian. I will read it in Georgian. სოფიოლობჟანიძის შეკითხვარი, არა, ბოდიში თამარსაჯაის შეკითხვარი, სტატინების რომელი ჯგუფია უფრო ეფექტური ახალი COVID ინფექციის დროს?
Okay, I think there's not really a statin that is distinctly different for COVID-19. Very simple. It's still a matter of inhibition of HMG-CoA, and that's reflected with LDL lowering. So I would favor the more potent statins. In terms of safety, there is some data that says, oh yeah, maybe pitavastatin seems to be safer, less diabetes, but realize also there's very few studies with pitavastatin. There's very few studies with a dose that is comparable to what we see with 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin. We see more and more evidence regarding the safety of those high-dose, high-intensity statins, also, you know, regarding muscle side effects. So I would still favor using high-dose, high-intensity statin in the context of COVID-19. The one caveat, as I said earlier, sometimes these patients have to use antiviral medication, hormones, corticosteroids. That could have an impact on the metabolism of statins, and then you have to be more careful. But that's in the setting of hospital care or even ICU care, and I'm not convinced we should continue statins in an ICU care, but focus more on the really acute problems with the appropriate drugs.
The next question. შემდეგი შეკითხვა არის სოფია ლობჟანიძის საინტერესო მოხსენება. მადლობა აქვე კითხვა, თუ აქვთ სტატისტიკა სრულად ვაქცინირებულ პაციენტებში ინფიცირება რამდენი პროცენტია და სიკვდილობა თუ დამდგარა სრულად ვაქცინირებულებში რა თქმა უნდა კოვიდით. თუ კი რამდენ პროცენტში? მადლობა. ანუ არ ვიცი რამდენად პროფესორ ლანსბერგს ამ შეკითხვაზე ექნება პასუხი, იმიტომ რომ ძალიან ზოგადი შეკითხვაა.
Okay, so yes, I have some information on that, and it's not that difficult. We know the effectiveness of the vaccine, which is roughly between 60 and 98%. In other words, 42%, despite vaccination, will get infected. So it's not 100% infection. I'm sure that other factors do play a role. You know, if you are immune compromised or if you have other risk factors or in a bad physical condition, of course, you're more likely to get infected. Or if you're in an environment where you're exposed to a high viral load, you're also more likely to get a SARS-CoV-2 infection. What is really reassuring to know is that your risk of being admitted in the hospital or having a serious complication or dying from SARS-CoV-2 is very low. So that's in the order of 0.1 or 0.2%. And again, these are patients that already are elderly, have other risk factors, not properly managed. So overall, in the general population, you know, the vaccines, especially the messenger RNA vaccines from Pfizer and Moderna, seem to be very effective in protecting the general population. There was just an FDA report that did point out that immune compromised patients are not that well protected. So even if you have your 2 shots and you know you have an immune compromised system because of a disease or drugs, you still need to be very careful and follow the measures as if you were unvaccinated. And they're now discussing maybe giving a booster shot, a 3rd injection to pump up your immune response in patients that were less likely to respond properly.
Thank you. There's a next question. Inka Baliashvili შეკითხვა არის post-COVID-ური გართულებებიდან საკმაოდ ხშირად გვხვდება ქვედაკიდურების ვენების თრომბოზი. თუ არსებობს კვლევები, რამდენად ხშირია ეს გართულება დიაბეტიან პაციენტებში, რამდენად უფრო მეტად ხშირად გვხვდება დიაბეტის დროს?
Okay, I think thrombosis and bleeding is a very high risk in COVID-admitted patients, especially in ICU-admitted patients. I haven't seen data that really distilled the diabetic patients as an exceptional risk factor for bleeding or coagulation-related disorders as stroke or emboli. I do know that diabetes per se does increase your risk, and you have to be better managed in your cardiovascular risk factors. Just as a non-COVID patients, we're now talking about should they not be on low-dose aspirin because of that increased risk. So I do think that the risk seems to be higher, although there has not been a proper paper that I can recall that showed that in good data, but it makes logical sense, and we need to be careful how to manage those patients. There have been quite a few studies looking at the new oral anticoagulant, the DOACs or NOACs, depending how you call them, if they could help if you give them preventively, so in patients not yet admitted to the hospital. Data is a little bit controversial. As I mentioned before, there was just a randomized controlled trial with heparin that showed quite interesting results in reduced admissions and better survival. So it's still an ongoing process that we have to learn about. And go back to the basic. Make sure patients are properly managed before you do something on top of that. And you know, if patients have risk factors for thrombosis, I would be very eager to early initiate antithrombotic patients. You know, if they have a history of VTE, or if there is a coagulation problem in their family, we have to be more alert on those type of patients.
Thank you. And I have the last question myself. I have a question regarding the keto diet and the lipids. So there are quite mixed cases when some patients who have hypercholesterolemia start keto diet and they have much better lipids. And there are some young patients that had absolutely normal lipids started keto and they have hypercholesterolemia, quite marked elevation of LDL. How can we explain these mixed results so we can see in our everyday practice and also their studies on it?
Yeah, I think that's still a very heated debate. You know, the keto diet, the vegetarian diet. I'm active on Twitter, and I see sometimes people becoming very aggressive if you're in the one group or in the other group. The main lesson I learned is that calories are the most important. If you want to lose weight, it's calories. And if you want to use the right calories, I would feel more comfortable with calories that are from natural sources, that are whole wheat, whole grains, vegetables. If you want to try a keto diet, I think there's quite a bit of evidence that it really improves your glycemic index. You know, you have less insulin, and that really translates in better outcomes for patients with metabolic syndrome or even manifest diabetes. Please try it, see how it feels. You have to monitor your LDL cholesterol because, like you said, there are patients that are, they call them lean mass hyperresponders. So these are patients that are very thin, they're very active, they're very sporty, but as soon as they take the keto diet, their LDL goes from 50 to 300 or 400. The theory is, and that is what they claim, that that's not important, that LDL is not really relevant, that it's a different type of LDL, and it's more important to have your glycemic index under control than your LDL under control. I tend to differ. I think if a keto diet is what you want and you feel comfortable with and you have a high LDL, then take a statin. Quite simple. You know, you can address both. The last thing I want to say about diets, and I've been you know, discussing this with patients for 40 years, the diet is not so much the challenge. Everybody can do a diet for 3 months, for 6 months, for a year, sometimes even for 2 years. But show me the people that really can stick to a diet for their life, you know, who really maintain it. These are exceptional people in certain contexts. And in our culture, you know, food also has a different connotation. It's not just like petrol for the machine. It has a connotation with friends, with family. You want to have the taste, you want to have the enjoyment, and that's sometimes forgotten. You know, I can't imagine doing a keto diet where you have steak in the morning, steak for breakfast, and steak for lunch. Yeah, I could do it for 2 weeks, but I would go crazy afterwards. And some of these people that do it are a little bit
crazy.
So no explanation for the mechanism. You know, take them by the hand and try to guide them that they, you know, fare well between Scylla and Charybdis and find a proper middle way that they can maintain for a long time, and that translates in better health outcomes.
Thank you so much. Thank you for your presentation, for your time, for your answers, and really hope to see you next time in Tbilisi.
Yes.
Face to face in a real meeting. So
yes.
Thank you, Dr. Landsberg. We missed you very much.
Thank you. Take care. And good luck with your meeting. And very good. In these difficult times, such an important meeting. I congratulate you. Fantastic job, Nadia.
Thank you. Thank you. Thank you for joining us.
Okay. Take care.
Okay. Have a nice day. And we will continue. Bye.